This is basically where you end up having something occluding the pulmonary artery, so the pulmonary blood flow is impaired to the lung parenchyma. Just definitions of terms. Thrombus is basically a stationary clot, where embolus is something that a clot that formed elsewhere that then moves to the lung. So in most cases, we have pulmonary embolism, not pulmonary thrombus that are created. Usually it's associated with a deep vein thrombosis, which usually implies something in the calf or the lower leg of some kind. You can also have an embolus that occurs by the release of fatty particles, specifically with long bone fractures. So it's quite common on a board exam to see something where they're talking about a patient who has a fractured femur and is having respiratory distress, and should automatically pop into your head, maybe it's a fat emboli that we end up having, and that's the reason for their problem. Air emboli would be something where somehow or other air got into the vascular system. Small amounts of air are not necessarily problematic, but large volumes of air are lethal. We see more of this with patients that have hypercoagulability, meaning that their blood clotting mechanism is out of whack and it's clotting too much. We'll see this with patients who are immobilized postoperatively. That's why patients, you'll often see them when they're not able to get up and ambulate. They have what's the word I want to use? They're almost like, I don't want to say balloons, but they're God, I can't think of how I want to describe it. It's like a wraparound that inflates and deflates. And what it does is it stimulates the muscles in the legs to, what's that? Yeah, compression. There you go. They also have specialized hosiery that they can have that are tight and allow for that also. What's that? Job stockings, yep. When I was traveling on the road, I used to stop every couple of hours. I had to force myself to stop to get up to walk around because there's that process that ends up happening. Those of you who are from my era remember a band called Jethro Tull. Ian Anderson had repetitive episodes of pulmonary emboli simply because of flying and sitting in a seat for that long.
There was that correspondent. He was in the, I don't know, one of the recent wars. I don't know if it was.
He was in the Gulf War.
Gulf War, okay. And
He ended up having a huge MI, or a huge PE thrown because of being in a cramped space. Right. So you end up seeing that with those kind of atrial fib, because of the irregularity in the atria's conducting process, and it's not pushing blood through. There's the potential for blood to coagulate within the atria and then be pushed out through the pulmonic valve into the pulmonary vein or pulmonary artery and having a pulmonary embolus, or out through the aorta and potentially into the carotid arteries and having a stroke. This is the classic example of a dead space ventilation, where you end up having ventilation without perfusion. It's ventilation that is wasted, if you want to think of it that way. It does not participate. In theory, a dead space should do nothing to oxygenation. Because if you think about it, if I don't have any blood flow going by, there's no harm, no foul. In the case of a shunt, in the case of a shunt where I have a shriveled up alveolus and I have a good alveolus, the blood flow from each of them are mixing together. This has a PVO2 of what? 40, right? This has a PVO2 of 40, but there's gas exchange that goes on here, so that this ends up being about 105 by the time it's all said and done. It's passed on through. but this is still at 40. So I'm mixing these together, which is going to make this, something lower, depending upon how much shunted blood you have. Follow me? In this case, when I have that mixing up, well, there's no blood coming here. So in theory, a dead space should not cause hypoxemia. But yet if you see a patient with a pulmonary embolus, they most definitely are hypoxemic. Okay? And the mechanisms of why that happens is a little bit confounding. I'm not going to expect you to grasp it just yet. We'll cover it again in the fall. But there's a couple of things I do want you to realize. I am blocking some pulmonary blood flow. How does the lung parenchyma receive its perfusion or receive its nutrients? It's the pulmonary capillaries, which means that if I have a reduction in pulmonary blood flow to a specific area, they're not getting they're not getting blood flow. They're not getting nutrients. What ends up happening, or potentially could happen, is what is called a pulmonary infarction. Just like a myocardial infarction, you can get a pulmonary infarction also. The pulmonary parenchymal tissue itself dies. Okay? But that is the classic, again, high VQ dead space that you end up seeing. And the way it's typically depicted is as that infinity sign. Because in reality, anything divided by 0 is undefined. Mathematically, that's kind of just the way they get around it. Now, what ends up happening when I shut off blood flow to that one alveolus, when this guy no longer gets any blood flow, there still is blood there, though. What it ends up doing is pushing the blood that would go to that alveolus somewhere else. So I end up having situations now where I end up having perfusion exceeding ventilation and a low VQ, which would be almost like a shunt effect. So that's why the PO2 falls. It's because I'm putting too much perfusion to an area that doesn't have the equivalent amount of ventilation to come. Not transit time, just the overall blood volume. Okay? If I have 5 liters of cardiac output, and that would be dispersed to my entire lung, and now I have, let's say, I have a big embolus, and I have a third of my lung no longer able to get because that big pulmonary artery is cut off, I still got 5 liters. But it's going to areas that are basically, I don't have the ventilation to accommodate it. Okay, so it's a VQ mismatch that you end up having. In addition, and this is kind of an academic thing more than anything else, you end up having a situation where that localized tissue that is in this ischemic state and is potentially dying, you have the body releases all kind of other substances to try and combat that death. Blah, 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 but it ends up having some reflex bronchospasm in the process. Okay. Enough of that. All I want you to know is that it's a dead space, and there is the possibility of having a secondary hypoxemia that you'll end up seeing with it. Special type of embolism is what's called a saddle embolism, and that's an embolism that occurs at the bifurcation of one of the large pulmonary artery branches, and in the process you can knock out an entire lung or an entire lobe, as the case may be. They're huge. Very high mortality. If you take a look at how these people present, they're short of breath, they're having some minor chest discomfort, not really chest pain, but just kind of an odd pressure. They may have a cough, they may have hemoptysis. That sounds like pretty much anybody. You know, most of the diseases we've talked about have some of those similar signs and symptoms. This is what makes pulmonary embolism so difficult to work with because it's hard to diagnose. I put this one on here, and I always get, anytime they see impending doom, a lot of diseases have impending doom. One of the worst scenarios is to have one of my ear nurse friends used to tell me they used to hate it when somebody would come in and say, "I'm going to die, aren't I?" It's like, oh shit, just ruined my day. 9 times out of 10, they arrest them 10 minutes later. But these folks are ones that they know something is wrong, it just doesn't feel right, and they're scared.
But that could happen with any disease, like if they're having
True. True.
probably they'll be like, I'll die.
Sure.
Something.
Sure. I mean, if you get a bad asthmatic in who's having a kind of like our case study. Oh, and by the way, on that case study, the actual best option as far as what the next intervention should be is mechanical ventilation. He's about ready to just poop on out. So if you chose that, get going. If you didn't, it's okay. You would have got there eventually. But this makes it really difficult to diagnose because, as what you're saying, there's so many other things that it mimics in the
What's
process.
the difference? Like, is there any?
This is a disease that we typically diagnose by exclusion. It's not this, it's not this, it's not this, it's not this. It must be a PE. We're going to go under the premise that it's a PE until we're proved otherwise.
It's also told with PEs they can also present with a temperature. Is that true?
Low grade,
Yeah.
yeah.
So more
But-
to mimic a
but not-
actual infection type thing.
Right, but the chest x-ray is going to appear
Out. Right. Absolutely.
that you don't have.
Probably get a history, and they'd ask, have you traveled any place? Have you been in a?
That's, again, this is how it's done, is it's done by, not so much by diagnostic tests necessarily as by ruling other things out. Yeah, Stacy.
One question, for the D-dimer test, can there be any false positives?
Oh my God, there's huge ones, yes.
So not just PE?
Yes, yeah. All of the tests that we end up having really at this point are not the best. The silver bullet has not been found to be able to diagnose it in the process. And as it says, most of the things we look at are really old and have never really been critically evaluated. D-dimer is one of them. It's a lab test that is done, but you can have that elevated for multiple reasons. So it's not always conclusive. There are some ECG changes that you might see. Lung VQ scans, if it's normal, you can rule it out. The problem is that there's so much else going on, and I'll talk about it in a half a second, as to why an abnormal value doesn't necessarily mean you have a PE, but normal, you don't have one, so that's the good news. High resolution CTs are kind of replacing VQ scans as a mechanism because they're a little more accurate. We've gotten better at reading them. What a VQ scan is we use two radioisotopes. One is radioactive xenon that is inhaled, and with a nuclear study, what ends up happening is a radionuclide is placed inside the body, and the amount of radiation that is emitted by you, the patient, is captured, as opposed to an X-ray where I'm taking a radioactive beam and putting it through you. This is one where we're actually putting a substance into you and you're emitting it. And this scintillation camera is basically a mechanism by which we can track how much of that agent is being exhaled or inhaled. We also put some radioisotopes into the bloodstream, and I'm looking and trying to compare how much ventilation and how much perfusion are going to the same area. So here's my ventilation scan, and here's the person's perfusion scan. Well, I would say there's some problem on this left-hand side. I have good ventilation, but I don't see the perfusion there. Okay. Problem comes up is, what if the patient's got COPD and doesn't have good ventilation to that area? And I'm not going to be able to pick up on the fact that the perfusion isn't matching it. Or what if they got real bad hypoxemia and we're shunting blood away from a particular portion of the lung? It's not a supremely conclusive mechanism. And like I said, CT scans, where they can pick up on the fact that there's a clot there, are starting to get a little bit better, more ground. Pulmonary angiography is the gold standard if we really want to get into it, but we don't, again, because of what this process entails, we don't utilize it that much if there's something less invasive involved. Basically, we're putting a catheter into the large vein, putting it into the pulmonary artery, injecting a dye, and then taking an x-ray picture to see if that dye is picked up. And this is an example where you would see the pulmonary vasculature well defined. Oops, nothing. So this is a massive pulmonary embolism on the left, saddle embolism probably. Just so you know that there's this thing out there, this is, again, one of these nondescript tests that can be done. It's called Homan sign, and you have a patient lying down, they lift their leg, and they dorsiflex their foot, pull it up, and if they have excruciating pain in their calf, it's a positive indication that they have a PE. But there's a lot of other things that can mean too. So again, not a conclusive one. So again, yeah, a lot of it's based upon history. We rule things out. Other things that can be causing the hypoxemia and the chest discomfort in the process. Small PEs will just have some hyperventilation secondary to the mild hypoxemia. If truly you have a saddle illness and something large, you probably are not going to have a blood gas done because you're probably dead. But again, you would have such profound hypoxemia that you develop a lactic acidosis as a side effect. We try to prevent as much as possible. So those patients that we know are at risk, we do things like use those elastic stockings or possibly even subcutaneous heparin to be able to reduce the clotting factors in the process. And the real goal is to get them active and upright as quickly as possible. If they're hypoxemic, obviously you would end up giving them some oxygen therapy. As far as anticoagulation, the two that we typically see are heparin and Coumadin. Coumadin being a pill, heparin being a subcutaneous injection. Beyond that, I don't really think you need to know what else goes on with that. In the case of a large clot, of saddle embolism, TPA can be used to bust that clot, just like we would do an MI. Okay. In theory, we could do a pulmonary embolectomy, go in and surgically remove the vessel that is there. I'm guessing that's probably not done too often, just because.
We were at, well, maybe not in the lung, but.
Oh, in other parts of the body, yeah. There's also what is called a Greenfield filter that is used for patients with recurrent pulmonary emboli. And this is basically something that is placed into the inferior vena cava. And it's like an umbrella that opens up and captures the embolus as it's coming up and does not allow it to go through. Okay. A Greenfield filter. That's what it kind of looks like. No, it can be removed at some point if they need be, or it can just be left in place. Extra piece of hardware for you. Well, hopefully it doesn't become totally occluded, or that would be something we have to go surgically go in and pull out. Stroke. Change that. Thank you very much. It's now the fourth leading cause. COPD passed it up. Yahoo. Good for us. No, I didn't say that out loud, did I? Two types of strokes that you can end up having cerebral vascular accidents that you can have. One is a thrombic event, where a clot is formed, either an embolus or a thrombus. And the other type is a hemorrhagic stroke, which are hugely fatal. I have a vivid memory of a 12-year-old girl who woke up with a headache. And the key part is the worst headache you could ever imagine happening.
Thunderclap?
Pardon me?
Don't they call it thunderclap?
Oh, I haven't heard that, but that's...
That's what I have to do prior authorizations for testing.
Mm-hmm.
That's on there. Thunderclap, the worst headache of life.
Yeah, and this girl...
It's supposed to sound like a thunderclap in your
Yeah,
head, I guess.
yeah. I'll buy that.
Yeah.
But she came in at 8 a.m. She couldn't go to school because she had this humongous headache. Mom brought her in. She was dead by 9. Just bled out. She had a huge cerebral bleed. So usually it's a cerebral aneurysm. And again, an aneurysm, if you remember back, is just where the vessel itself the wall of the artery becomes soft, and it ends up spreading, and it balloons out, and eventually it ruptures.
Didn't she have any symptoms that before?
Headache. Massive, woke up with a massive headache, and that was it.
I had a friend.
And, I mean, no, it's rare, but I mean, it can happen to anybody. There's an argument I've heard that we all have cerebral aneurysms, and if something doesn't kill us before, they'll kill us eventually. It'll rupture. This is an example of the thrombic mechanism where the blood flow can't get by because of this occlusion there, and this is basically the cholesterol and plaque that is the atherosclerotic plaque that is developed along the wall to make that narrow, and this lodges in there, and no blood flow goes through. Your brain requires oxygen and glucose to survive, and if you don't have it, you're going to stroke out. And what ends up happening then is the localized swelling happens. And again, the problem with that is that you have a fixed amount of space within the cranium, and large strokes, especially hemorrhagic strokes, can lead to a brain death situation. Symptoms, numbness and weakness of some portion of your body. Typically it's unilateral, one side. Confusion or difficulty in speaking, slurring of words, using inappropriate, the word is inappropriate for the sentence. Vision problems, double vision, blurred vision, loss of balance and coordination, and some other symptoms that are there also. But basically it's a sign neurologically that your body is not responding. It's opposite of each other because of the, I forget what the name of the chiasm in your brain, where the right feeds the left and left feeds the right. But so if you have a right-sided clot, you're going to have a left-sided paralysis in the process. TPA is the only approved thrombolytic that can be used to dissolve the clot, but here's the bad news. It has to be started within 3 hours of the onset of the event. And you have to, as part of that process, do a CT scan to verify that it's a obstructive clot, not a hemorrhagic stroke. Most people who have chest pain, who have an evolving MI in the process, present to the ER within the first few hours. Most patients who have stroke present about 12 hours later. You know, you wake up, your arm's not moving, I just slept on it funny. I'll go back to bed. No. So, very few patients are eligible for this therapy, even though it's life-threatening. Okay. Just like muscle is time with a myocardial infarction, we want to get that area reperfused as quickly as possible. This is brain is time. So the more we wait, the more damage ends up happening. Just another picture there. There are something called transient ischemic attacks, TIAs, that often precede a major stroke. These are areas where, for whatever reason, the blood flow is reduced, but then it's reperfused again. During the time where the TIA is happening, the person might lose, I don't want to say lose consciousness, but lose awareness of where they're at, and it's kind of in a fog, and then it comes back again. Usually, like again, there's not permanent damage that is present, but it usually is a symptom preceding one. Yeah.
You know the pathology behind Bell's palsy?
Well, no, I don't. To be honest with you, it's if my memory serves me correctly, it's an autoimmune response where there's swelling on a specific nerve, and in most cases it resolves itself, but not always. And beyond that, I can't really. But Bell's palsy is one of the things that you want to rule out when you're trying to rule out a stroke, because some of the symptoms with Bell's palsy, you end up having facial droop, slurred speech, but really nothing of the other components as far as peripheral muscle weakness. So again, treatment is just basically trying to get the patient to the hospital as quickly as possible. There actually is what's called the Cincinnati Stroke Scale, where you look at, have the patient smile, and if they can't smile, if their one side is weakened, that's a sign. You have them hold their arms out, and if you're having a stroke, you can't keep the one arm up. You have them say a specific sentence, say the Pledge of Allegiance, say, whatever, and the words just aren't rhyming right. I think there's another one in there, but there's a series of steps at the end of trying to
What do you see
classify it as.
an acronym of the FAST? Face,
Arm,
arm, speech,
Speech.
and time.
time. Oh, maybe just time as far as when did the symptoms first come up, yeah. So again, for our purposes, really it's just monitoring the airway. Because one of the things that can end up happening is you end up having impairment in the ability to cough and swallow, which means you can have situations where the patient potentially could aspirate. Okay, and obviously oxygen therapy might be indicated if they're having some ventilatory issues. Usually it's not. Usually it's more motor, peripheral motor than it is anything else. And managing the blood pressure by treating the hypertension. Anybody got to guess what that is? What kind of peanut? An assaulted peanut.
Assaulted. Get it.
It's a real knee slapper.